Dysphagia, or difficulty swallowing, is commonly reported by the patients as food getting stuck. In this video, we'll go over the 4 W questions approach to dysphagia. These are where, what, when, and how. So where stands for where does the food get stuck? At the level of the throat or the chest. What, to what kind of food is the dysphagia? Solids or liquids? When stands for the timing. Is it intermittent or getting progressively worse? And lastly, how refers to the associated symptoms. How does the dysphagia present? Does it present with heartburn, weight loss, or pain? So let's start with the first question. Where? The food might get stuck at the level of the throat or in the chest. In the throat, this region is called the oropharynx, and the patients will report the difficulty with the initiation of swallowing. So they will start coughing and choking on the food, and it will come out of their nose. The second possibility is that the food is getting stuck in the chest, and this is esophageal dysphagia. Let's start with the oropharyngeal. Remember that the oropharynx is made of skeletal muscles, and these muscles are innervated by nerves, which are controlled by the brain. So the problem might be neuromuscular, like for example a stroke or a myopathy that affects the skeletal muscles. Or it might be structural, like a tumor or compression by an enlarged thyroid. In most of the cases of oropharyngeal dysphagia, the best initial step is modified barium swallow. Now let's shift gears and talk about esophageal dysphagia. The second question will be, to what kind of food is the dysphagia? It could be either both solids and liquids, or only solids. And this divides the causes into motility and structural. In the case of a motility problem, the muscles are not contracting well, so solids or liquids wouldn't be propelled along the esophagus. But in the case of structural problem, liquids would be able to pass by the structural defect, but the solids might get stuck. The next question is, when does this happen? Is it intermittent or progressive? Let's start with the motility side. The next question is how, or how does it present? These are the associated symptoms. So if it's intermittent and it presents with pain that looks like a myocardial infarction, but the workout turns out to be negative, there are no cardiac enzymes, no ECG changes, this is esophageal spasms. Next, let's explore the progressive causes of this motility. If it presents with heartburn, that means that the lower esophageal sphincter is not working well, and this is seen in scleroderma. What happens in scleroderma is that the smooth muscles are getting replaced by fibrous tissue, so the lower esophageal sphincter tone is lost, and there will be an acid reflux resulting in heartburn. On the other hand, if the patient presents with symptoms of regurg or aspiration with respiratory symptoms and weight loss, this is seen in achalagia, which is failure of relaxation of the lower esophageal sphincter. So the food builds up there and starts regurgitating back with symptoms of aspiration. Let's shift gears to the structural problems. If they were intermittent, that means it's either a ring or a web. If it's progressive, we explore the symptoms further. If it presents with heartburn, it means that this is a peptic stricture. From the chronic damage by the acids, a stricture would form at the lower esophagus. On the other hand, if there are risk factors and a significant weight loss, this is esophageal cancer. Risk factors include smoking, chronic use of alcohol, and age above 50. For the investigations of esophageal dysphagia, the best first step is an endoscopy plus minus a barium swallow. If they turn out to be negative, this excludes structural problems, and we go for a manometry to look for motility disorders.